Good afternoon, everyone, and welcome to the afternoon session after lunch. I hope I'll keep you awake throughout this session. As has been discussed by Clara and by my task was to implement to help with the implementation of the Citizens Report Card at the community level, at the grassroots level, working with the community-based organizations, as I'll discuss. My job was to work on, now my presentation will cover the implementation, the activities that were involved, highlight some of the challenges and the lessons. There was a lot to share, but I tried to summarize so that you don't stay here until midnight. The objectives of the CRCCL were as Martina has mentioned, and I'll put this in basic language, where the community demanded accountability and responsiveness to the community's needs in health service delivery in Health Center 3s, and the community and the health center staff, based on the report card information. I'll show what a report card looks like later on, providing information on the performance of their health center, were then able to identify priority areas for action so that they can focus on those areas that are most important. And on that basis of identifying the priority areas, they then generated suggestions for improvement in the services, and then both the health center and the community staff then jointly identified and implemented specific actions to improve the quality of service delivery. But it was emphasized that it has to be within a given time frame and also without any additional resources, either from government or elsewhere. So they had to use what was available. The project management, Martina talked about the Ministry of Health having requested for the initiative, and then the JPAL researchers, Martina and Jacob, as well as the social development team at the World Bank that helped with designing the survey. In Uganda, we had the Uganda project management team that was headed by myself, and I coordinated the activities on the ground. We also had a trainer who was specialized in participatory methods, who was able to train the different facilitators so that they can implement the process in exactly the same way in all the treatment facilities. Then we also had a local-based CPO coordinator, a community-based organization coordinator who was able to work with each of the CPOs individually to bring them together, to mobilize them, and then I followed up with the coordination activities. The grassroots implementation partners included the community. For the community meetings, at least 50% of the people who attended had to be women because they use the health facility for delivery, antenatal care, to take their children for medical treatment. We also had leaders where we had the chairpersons, women's representative, youth representative, and the disabled representative. We have a local council system in Uganda, and that's what we use a lot of. So these were local council, village level leaders. Then we also had special groups where we had the mothers specifically represented at the meeting, the disabled. We also looked at age groups, the youth, the middle-aged people, and the elderly. The criteria were broad, the youth between 15 and 25, then the middle age and the elderly. And in each group we had both the male and the female. We also had the low-income group and the high-income group because they would all have unique needs. Then the health centers, we had all the medical workers. We encouraged all of them to attend. The CBOs were really the neutral, they were neutral people. They had a local presence, but they were also neutral in that they were not people who were delving into either both the community or the health facility. We also assigned a research assistant for support for the facilitators. And the CR process itself, first it included preparatory activities. Then we had both health center staff meetings and the community meeting. We had an interface meeting between the community and the staff, and then the implementation by the community and monitoring by the community as decided in the interface meeting. I shall go through what the activities and the challenges in each component. For the preparatory activities, the project was piloted extensively, so that to know the best fits, first that will need information, we'll have to have the meetings, and then we'll also need to have a component of role play. So that was agreed, that was decided after the piloting. Trainers were identified, the trainer. We also identified the community-based organizations and the NGOs that had a local presence in those communities where they can work with minimal resources, because it was a small project, so there was very minimal additional support. We prepared the materials for both for the training and the report cards for the meetings themselves, as well as translation into the local languages. We obtained the Ministry of Health, because they were really a huge part of it. They provided the letter so that we could obtain permission for the health center and the community meetings from the District Director of Health Services, so that we can talk to the staff, and then from the Chief Creative Officer, so that we could talk to we can hold the community meetings in their area of jurisdiction. Then the participants were informed about the meeting and what it required. We agreed, and then together with the participants, we agreed on the meeting venues and the times, as well as the logistics that would be required for the meeting to take place. Some of the challenges originally, during the preparatory stages, the intention was to have one NGO that has a presence in all the treatment communities. It was a very, very difficult challenge to get one that could do that. So that's why first we had to have individual consultants like myself to coordinate the activity, and at the same time work with several CBOs and NGOs that had a presence in those areas. We also, there was a challenge, because this process is a community-based process, and it had to be driven by the community members themselves. So they had to be able and willing to talk and to participate in the meetings. Otherwise, if they just came and sat there, nothing would be done. So we emphasized the selection criteria. First, we needed the different categories I mentioned earlier, and the participants had to also be able and willing to talk and not cause fear or intimidate other group members. The venue had to be central, easily accessible, and protected from the rain for obvious reasons. The meetings were planned for the afternoons after the activity, so that people could attend after the people had worked in their gardens, after the staff had treated patients. So we had to think detail. And because people would come straight from their gardens to the meeting, we had to organize lunch so that they can eat first before the meeting, and because it was intense. But we also made sure that the lunch is prepared by the community. So we provided some lunch money, so that some money can stay in the community. And then because it was over 5-kilometer radius, some people were from far and from near. We gave them a nominal transport allowance so that people can at least come to the meeting. It was not much. Yeah. So the next, I'll go into the implementation activities. We started with a health center staff meeting, because it was something that happened for the first time. The health center staff were very, very tense. They thought that they were going to be monitored and hunted down. So we had to make sure that they know what is taking place, and to make it a very transparent process so that people can participate. So what started the process was the presentation of the public health entitlements under a Yellow Star program for the Ministry of Health that had been funded by the USAID. And there were simple entitlements: the right to confidentiality, free health care, polite treatment to staff, to the community and their attendants. Those were some of the things that were included in the public health entitlements. So these were presented first. And then the presentation of the report card findings in the 4 broad categories: utilization, how often do you use the health center, where do you go, the services in general, including politeness, waiting time, issues relating to drugs availability, user fees, and then comparison with other similar health centers across the district and nationally. Then we also employed focus group discussion with the different groups to enable maximum participation in the process. And then for them to develop group action plans, which they then harmonized at the end to form one actual community health action plan to take to the community meeting, or for the health staff, a health facility action plan. This is an example of one of the report cards that were used, And you can see some possible sources of tension based on the data that were collected, as highlighted. For example, based on the data, the average waiting time for patients at the health center, the households on average say 2 hours, and the staff say 2 minutes. This is for one health center. So you can see that as we talked, as Martina mentioned about the role plays, there were certain obvious disparities in what people perceived. So those are some of the things. And then I just also presented another issue regarding to the fees and user charges. No user fees are supposed to be paid in the health centers in Uganda, but you can see that 45% of the households said they paid some level of fees, while the health facility staff said there were no fees paid at all. So, and for the interface meetings, still just to make sure that we were all on point, there was a presentation of the public health entitlements by the facilitators. There was a role play on service delivery at the health center by both staff and the community, and Martina mentioned that the roles were interchanged so that certain unique issues could come out. The presentations of the action plans by staff and the community representatives, and then the final action plan including what action will be taken, who will take the action, when, and indicators of monitoring progress. And monitoring was agreed still at the interface meeting by both the community representatives and all the other officials that were assigned at the interface meetings. This is an example of the interface meeting action plan. This is also taken from one health center. For example, if we look at politeness of staff, we have the issue that came out from the communities when the in-charge is not at the health center. Staff are rude and unruly for one health center. So the in-charge may not have known that the staff were rude, but this is some that came up. And then that was one of the agreed action points at the beginning in the interface meeting, who was responsible and when the activity would take place. So some of the challenges that took place was the suspicion and fear by the community and the health center staff. For example, the community at first said, won't we be witch hunted? Won't we be, punished when after the end of the process? Meanwhile, the health center staff, some of them had been doing some things that were not right. For example, selling syringes. And we had cases where maybe a midwife runs away on the day of the meeting because she knows that she's done something wrong, and then so things had to be diffused, but there were some initial challenges. So there was clear emphasis by the facilitators that this was not a witch hunting exercise. It was really the community and the staff coming together to work on improving the quality of service delivery in their health center. And we also mentioned that we employed CBOs that were engaged in those communities in other activities. So since they were in education and health, they were not foreign in the community, so that was also very helpful. We also had a concern in the design about the different groups not being able to contribute, but employing the focus group discussions and also the facilitators ensuring that everyone is able to contribute. Another issue was because this is a time there's so many burning issues, so it was important that the actions were realistic and achievable. So over and over again, the emphasis, no additional resources. It has to be things that you can do, and you can do without additional support, and it has to be within a reasonable time frame, because we always know that if you make the time frame too long and you don't see any immediate results, you lose energy and you lose momentum. So that's one of the things that were emphasized. For the interface meeting, there was possible friction and finger pointing. Still, we emphasized the meeting objectives. There was evidence from the community and the health center action plans and the role plays that both groups had areas for improvement. Because in some cases, the midwives would say we're rude because women just come from their gardens when they're dirty for antenatal treatment. We get frustrated. So then the community knew that we have to clean up fast, simple things. And then there was also, we had to have moderation by the lead facilitator to diffuse tensions. but the tensions eased a lot after the role play, whereby the community and staff played each other's roles. So everybody walked in the other's shoes, and all things that were not clear came to light, and that was really very useful, and it helped with cohesion and cooperation in developing the action that came later. And also this process helped with the communication by the health center staff about the causes of some problems, because in some cases there was suspicion that maybe the drugs are sold, but then the in charge would stand up and say, okay, this year we've only received 2 shipments of drugs, for this given period. So things were clear. We've just received Panadol and chloroquine. So things became more transparent, and people became more understanding and realized they needed to work together. The lessons were learned were that the participatory methods and how they were implemented enabled the community and the staff to meet, to discuss the performance of their health center, and together develop solutions for improving service delivery. The data that Martina has presented, the results are evident, but this would not have happened. The communication and information sharing were critical to improve cooperation between the community and the health center staff. The challenges were surprising to both groups in some cases, and also there are some things that had been that the community wanted that they realized that couldn't be done. For example, for dental services at the health center 3 levels. It was also evident that the community and the staff were in best position to prioritize the simple changes that influence the perception of service delivery. In some cases, the things that needed to be changed were small: put a suggestion box, put a duty roster, train, disseminate information. The communities were very engaged and willing to provide practical solutions to their problem. And even when with limited budgets and without direct government intervention in terms of money, there were some changes some improvements could be made in service delivery. We've seen the data presented before. And in some cases, it appeared that the staff wanted to provide better services, but were constrained and did not have alternatives before this intervention. We also had feedback and monitoring, where the community members that attended went back to the rest of the community to talk about what had happened, so that everybody knows. And there was a display of posters about the public health entitlements and free services at the health center. And then the people assigned the tasks in the action plan went back and continually monitored progress to make sure what had been agreed in the interface meeting was taking place. There are some challenges with that process, because in some cases you had a committed in charge that was subsequently transferred by the ministry. So someone came in and they had to be brought on board. And then we also had scenarios where first the problem was there were few staff, but then the few staff were further transferred from the health center. So as you can see that at the top level and the bottom level, there was in some cases what was happening, what was being agreed was being affected by the top level changes. And then even despite the activities by the in-charges, issues that had to do with the ministry or government about drug deliveries did not take place despite the action of the in-charges. In conclusion, the changes in service delivery implemented through CRCCL, I'll now call it the CRCCL, intervention resulted in measurable changes in some indicators. Martina has talked about that. The information provided through the public health entitlements, through the report cards, and through the role plays, and the ability to interface started a process of information sharing, improved the relations between communities and the health center, as we saw in subsequent meetings where there was much greater enthusiasm when we had the second phase, and then there was joint action planning to improve health services. So thank you very much, but it was a new initiative for me as well. I found it extremely exciting and highly rewarding, and especially when you saw how much the communities were engaged, people working together, calling it, for the first time, instead of saying the government health facility, they started calling it our health facility. So that was very rewarding. Thank you for listening. Bye.